Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
All right, welcome back to the deep dive. Today, we are tackling a class of medications that is, it's just everywhere. In hospitals, pharmacies, and unfortunately in so many critical toxicology cases.
We're talking about anxiolytics, sedatives, and hypnotics.
Right, ASH for short. And these are basically substances, xenobiotics, that limit how excited your brain gets.
Exactly. They either calm you down, make you drowsy, or put you to sleep. And our mission today is really to get into the weeds on this because, while they all might seem to do similar things, their potential to be fatal could not be more different.
And the sources we're pulling from today, they're mostly from advanced toxicology curricula, stuff designed for doctors and pharmacists. So the goal is to highlight not just what they are, but why they're still such a huge public health issue.
It's just essential knowledge given how many people use them.
So let's start with just how big this landscape is. People hear sedatives and they think, what, sleeping pills? But the uses are so much broader.
Oh, absolutely. We're talking about critical drugs for agitation, for managing really severe substance withdrawal.
Like ethanol withdrawal, that's the classic one.
Right. And then you have seizure disorders, where things like phenobarbital are still the standard of care.
And that's not even touching on things like anesthesia, propofol, for instance, or all the different insomnia drugs, from Z drugs like zolpidem to, the newer stuff.
And that wide range of uses, that's actually a huge risk multiplier.
Okay, why is that? Why does being useful make them more dangerous?
Because it means they are everywhere. And history shows us we have a bad habit of pushing the safety boundaries with these. You look back at barbiturates, introduced around 1903, they were incredibly effective. But they had a fatal flaw, a really narrow therapeutic index. The dose you needed to get an effect was just way too close to the dose that could kill you.
And that led to, it was practically an epidemic of overdoses in the mid-20th century. You see it in old movies all the time, the barbiturate suicide. It wasn't just a trope.
It was reflecting reality. The big change came in the 1960s with benzodiazepines, diazepam, for instance. They had a much better safety profile, and they just took over the market.
It seemed like the crisis was solved.
Seemed like it. But really, the crisis just changed shape. Even with these safer drugs, ASH agents are still in the top 5 causes of overdose deaths reported to poison control.
And this is the key point, right? The danger today isn't so much one drug.
No, it's almost always the combination. The vast majority of deaths involving benzodiazepines happened because they were taken with something else.
Specifically opioids.
Opioids, alcohol, any other respiratory depressant. The synergy there is, it's just profound. They work together to shut down your breathing.
Okay, so let's get into the science of it, the aha moment.
Yeah.
How do most of these, the barbiturates, the benzos, the Z drugs, how do they actually calm the brain down?
They all, for the most part, target the brain's main brake pedal, a neurotransmitter called GABA.
Gamma-aminobutyric acid.
That's the one. And these drugs, they basically make that brake pedal work better. They're agonists at what's called the GABA-A receptor.
And how does that work mechanically?
Well, when the drug binds to the receptor, it helps GABA bind more effectively, and that opens a channel, letting negatively charged chloride ions rush into the neuron.
So you're flooding the cell with negative charge. That hyperpolarizes it.
Exactly. It makes it harder for that neuron to fire an electrical signal. You're dampening the whole system. That's your sedation.
I've read that different parts of that receptor do different things. Is that where the Z drugs come in?
That's a great point. The GABA-A receptor is a complex of different subunits.
Yeah.
And which subunit you target changes the effect. The alpha-1 subunit, for example, is mostly responsible for sedation.
And that's what zolpidem targets.
Exactly. It's designed to just target sleep, whereas the alpha-2 and alpha-3 subunits are more involved in anxiolysis, the anti-anxiety effect.
It's a more surgical approach, but okay, we mentioned there are some special agents, drugs that don't use the GABA system at all.
Right, and they were designed that way to, try to lower the abuse potential and get away from the withdrawal problems. You've got Rameltian, for instance.
That's a melatonin agonist, right?
Exactly. It just mimics your body's natural sleep hormone to help regulate your circadian rhythm. It's more of a clock adjuster than a brake.
And suvorexant, that one's interesting.
It is. It's an orexin receptor antagonist. Orexin is what tells your brain, stay awake. So suvorexant just blocks that signal. Then you have dexmedetomidine, which is an alpha-2 agonist used a lot in the ICU. It causes sedation without the big risk of respiratory depression you get with GABA drugs.
Okay, that brings us to what might be the single most important part of this whole discussion. The life or death difference between a barbiturate overdose and a benzodiazepine overdose. What is happening at the molecular level?
It all comes down to how they interact with that chloride channel.
Let's break that down. Benzodiazepines first.
So benzos, the safer class, they are indirect. They only increase the frequency of the channel opening.
So how many times it opens?
Right. But, and this is the crucial part, they can't open the channel by themselves. They need GABA to be there. So even at really high doses, their effect has a ceiling.
A plateau. So that's why an overdose on benzos alone is rarely fatal.
Exactly. The body still has some level of control. Now compare that to barbiturates.
The ones with the highest risk.
By far. They don't increase the frequency, they increase the duration. They hold the channel open for longer each time.
Okay, and at high doses?
At high doses, they do something benzos can't. They can directly open the GABA chloride channel all by themselves. They don't need GABA anymore, they just take over.
They don't just help the brake pedal, they become the brake pedal and jam it to the floor.
And that leads to this profound CNS depression, coma, circulatory collapse. And what's really scary for clinicians is that the neurologic exam can look identical to brain death. Non-reactive pupils, no brainstem reflexes, a flat EEG. It's a terrifying mimic.
Wow. That is a critical point of confusion. We should probably also touch on a couple of other unique toxicities, one old and one new, just to show it's not always about GABA.
Good idea. Let's start with chloral hydrate, the old Mickey Finn.
Right.
Its active metabolite, trichloroethanol, does something very different. It makes the heart super sensitive to catecholamines, like adrenaline.
So the cause of death there isn't usually from respiratory depression, it's the sudden cardiac dysrhythmia.
Exactly. The heart just gives out. A couple of clinical clues for that one: a pear-like odor on the breath, and the tablets can sometimes be seen on an X-ray.
And the more modern, unique toxicity, the one that comes from the IV fluid itself.
Right, propylene glycol toxicity. It's the diluent, the carrier fluid, in IV lorazepam and diazepam. When you have a patient in the ICU on a high dose, continuous infusion,
Which happens a lot.
it does. That diluent can build up and get metabolized into acids, causing a really severe metabolic acidosis and a hyperosmolar state. It's a tricky diagnosis if you're not thinking about the diluent.
So you have to look past the drug itself. Okay, let's shift to long-term use. People develop tolerance. They need more of the drug to get the same effect. Why does that happen?
It's a pharmacodynamic change. The body is trying to reestablish balance. So it physically starts to downregulate or desensitize those GABA A receptors.
It's changing the locks, not just ignoring the key.
That's a great way to put it. And that leads us to the most dangerous part of chronic use, withdrawal. And we have to be absolutely clear here.
This is not like opioid withdrawal.
Not at all. Opioid withdrawal is horrible, but it's generally not fatal. ASH withdrawal is absolutely potentially life-threatening. You take away that chronic break, and the central nervous system just goes into a state of extreme hyperactivity.
What does that look like?
It starts with restlessness, tremors, but it can escalate fast to agitated delirium, psychosis, hyperthermia, and the big one, seizures.
And the timing of when that starts can be tricky, right? It depends on the drug.
It absolutely does. It all comes down to the drug's half-life. A short-acting benzo, like alprazolam, is out of your system quickly. Withdrawal can start in 24 hours.
But the long-acting ones are different.
Very different. Something like diazepam has active metabolites that hang around for days. They basically give you an automatic, built-in taper. So the withdrawal might not start for 4, 5, even 8 days.
Which is incredibly dangerous if you've already sent that patient home.
It can be a death sentence if they have a seizure alone.
Okay, let's finish up with management of a severe overdose. I assume it starts with the ABCs.
Always. Airway, breathing, circulation, that is number one. You secure the airway, often with intubation, you support their breathing, and you treat their hypotension with fluids and pressors.
And what about getting the drug out of the body? I know there's one technique that's particularly useful for the old barbiturates, like phenobarbital.
Right, you're talking about multiple dose activated charcoal, or MDAC.
MDAC.
Yeah, it's a pretty interesting tool. You give charcoal over and over again, and it basically creates this sink in the gut. The phenobarbital, which recirculates through the liver and gut, gets pulled out of the blood and trapped. It can cut coma time significantly.
But I imagine giving charcoal to a comatose patient has some serious risks.
A huge aspiration risk. You pretty much have to have the patient intubated to even consider it. And barbiturates themselves slow down the gut, which can make it even harder. So it's a very selective, advanced technique.
Okay, finally, let's talk about the big controversy, the antidote that we almost never use. Flumazenil.
Ah, yes, seizure juice.
Why is this tool, which can rapidly reverse a benzodiazepine overdose, so dangerous?
Well, it works. It's a competitive antagonist at the GABA A receptor, so it just kicks the benzos off. The problem is, the risks are often way worse than the sedation.
What are those specific risks?
There are three big ones. First, if your patient is a chronic user, giving flumazenil will rip the benzos off their receptors and throw them into immediate, life-threatening withdrawal.
Seizures.
Exactly. Which is risk number two. It can precipitate seizures even in someone who isn't a chronic user, especially if they also took something else that lowers the seizure threshold, like a tricyclic antidepressant. You're trading sedation for status epilepticus.
That's a terrible trade. What's the third risk?
It's very specific. It's absolutely contraindicated in a chloral hydrate overdose. The reversal can trigger a massive release of catecholamines, which, on a heart already sensitized by the drug,
Leads to fatal dysrhythmias.
instantly. So you keep flumazenil in the box unless you are 100% certain it's an acute, isolated benzo overdose in someone who never uses them. And even then, you think twice. Supporting the ABCs is always the safer bet. You know, if there's one single takeaway from all of this, it's that molecular difference. The effects look similar, calm, sleepiness. But the safety profiles are worlds apart.
Yeah.
It all comes down to that one thing.
Yeah.
Are you just modulating the frequency of a channel opening, or can you directly force it open yourself?
That distinction really is the line between sedation and death. So thinking about the big picture here, we've seen that managing these poisonings isn't just about chemistry, it's also about, well, physics. We talked about how something like imdeteri can manage a long-acting drug like phenobarbital, but then you have another old drug, imiprovimate, that can cause delayed toxicity just because it forms a literal rock of pills in the stomach, concretion, that just keeps dissolving. So it makes you wonder, how much of critical care is about supporting physiology versus just anticipating these incredibly complex, sometimes unpredictable toxicokinetic phenomena? Something for you to think about until our next deep dive.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.